We got a few studies on the docket today. Uh, there's only really one or two that I have really an opinion about, but the rest of them, I just want to bring to your attention, say a little piece about them, and hopefully provide some clarity on social media and YouTube. Because if you've watched it like I have lately, it can be just as confusing as it can be clarifying. You hear so many things on so many different opinions. It can be a bit ridiculous. So let's hop right in and see what we found this week with our studies. First one, functional and neuromuscular effects of rehab in acute ankle sprain and chronic ankle instability. The study actually just took those who had chronic recurrent ankle sprains, comparing them to acute lateral ankle sprains. And they wanted to see how they improved on traditional rehab protocols, what improved between plantar flexion, different motions for the ankle. The reason that I brought up this study is in the conclusion, they thought that there were some sort of limitations because there were still neuromuscular deficits found even after the standard rehab protocol, which brings into question, you know, what are the protocols really catching? What are they leaving left on the table? And the authors wanted to call for more personalized rehab protocols to be developed, especially with integration and utilization of technology. And that's the big thing that stuck out to me, especially because at this office, we utilize that technology so that we're not on standard protocols or standard return to play protocols based on time and time alone, or purely visualized limb symmetry. We actually will measure these things, put people on force plates or a dynamometer, and just figure out where were you at, where are you at, and where are you at compared to your same age and sex matched uh, colleagues. So if you have, you know, 10,000 30-year-old males, where would you match in that cohort? So how potentially healthy is your body region that we're testing in the test that we're actually doing? So I like it because it kind of tickles my bias, like the authors are calling for things that we're already starting to establish at the office. So I just thought it was kind of cool that we're seeing calls to action for developing new protocols to essentially combat what is or what was good enough. I think if there's any rant that I could have from this, it's really that I am getting kind of sick and tired of a lot of different clinics, providers, and systems settling for the it's good enough or what we've always done. I've had a lot of patients tell me that story either directly or indirectly, and you kind of get the understanding that they went through a process of it was good enough or it was the model that they always follow, just because whether it's insurance, that's all that insurance covered, or that is always the post-op protocol, regardless and irrespective of how athletic, fit, underweight, overweight the individual is. That's just the cookie cutter style that it's just not good enough anymore. So hopefully that call to action will bring more powers that be to start adapting and adopting new technologies that are more widely available to give a more customized program for the individual in front of them, following guidelines but not being shackled by them. Hope that helps. Next up, this is a new bit of anatomy. So there is a potential connection. I shouldn't say potential, depends on how you dissect a cadaver. What they purport and what other studies have found in even several years ago is a connecting ligament between your muscles of the neck to the actual covering of the spinal cord. So if we can kind of envision layers going down, you have skin resting on top of muscle, muscle resting on top of bone, bone encompassing the actual spinal cord, and you have to have tissue that can go in and out of the cord itself to allow for us to move, feel, and everything else. Because if nothing could get out of the cord, we wouldn't survive. You have to have nerve paths and different openings in between the spaces of the bone to allow nerves to travel through, blood vessels to travel through, all that jazz. Well, especially in the upper part of your neck, there seems to be a cross bridging connective tissue, this um, like a cervico-dural. So from cervical musculature to the dural covering of the spinal cord, a cervico-dural bridge that connects muscles outside of the cord to the actual dura around the cord, and that may be a potential cause or reason why people get certain types of headaches and neck pain, or neck pain again associated with other secondary symptoms and other secondary headaches or primary headaches. I don't know. It's late when I'm covering this. Um, it's cool in the sense that we're discovering new things about the body. It's clinically relevant because this may give us a reason why, in certain people's cases, manual therapy and adjusting help with what we think is a cervicogenic headache. And it also may give us a reason why other patients may not be getting better and give us a different potential mechanism on why they're not getting better and then reclassify their headaches accordingly. So this really highlights that we are learning more about the human body day by day. This is still an art, not just my specific profession, but treating humans, pain, etc., at large, because we are still learning more about the human body, how things are affected, what affects it, how to help, etc. And this as a potential mechanism of why we suffer certain things like cervicogenic headache. Well, what causes cervicogenic headache? Is it just joint or nerves that surround joints that tell us where we're at in space misfiring? Well, yes, that's still a potential theory, but now we have this added potential mechanism to that diagnosis of, oh, maybe there's something between the muscles, the muscle tone, what they're choosing to do on any given basis, how contracted they are, that could be playing a role in tightening up that dural bridge, that could be causing a mechanical strain on the dural sac in that region, causing a cervicogenic headache, which then could possibly explain why manual therapy, adjusting, dry needling that relax the muscles and or the surrounding joint tissue, and it will then relieve this person's headache. So it's a potential mechanism. We're learning more about the body. It really demonstrates that we're still at the this is an art phase. Moving on though. Manual therapy and exercise targeted to the neck and oral facial regions for patients with oral facial pain. Really just a synopsis of, manual therapy and targeting the neck, face, etc., can help with various oral facial conditions. Um, it's more. I'm showing you this study for things that we've already done in the office. It's definitely don't overpromise, but also don't take away from the patient's behalf. And what do I mean by that? I mean, some providers will purposely not tell patients about certain procedures because they're concerned that there's like either zero possibility it can help, taking patient autonomy out of it because you think as the provider you know best in all scenarios, which does happen. Um, and not even offering a patient a possibility. And one way we can phrase that is, hey, we see these summary research summaries showing that in some instances, manual therapy to both the neck and or um, face and TMJ region can help people with conditions like yours. I'm not going to throw it out as a guarantee, but I'm not going to not tell you about it because maybe I have a bias like, oh, it's probably not going to work in her case. Well, who am I to judge, right? Who am I to not give her or him the option to receive that care as long as I give them the informed consent about what I'm actually aiming for? I kind of got skewed off on a side tangent on that one. Long story short, we treat oral facial pain in the office. We're very deliberate about how we present it because you know what? In some instances, patients will describe the relief of pain that they get because this can be such a pervasive and disabling region to develop pain that even the gaps and breathers and breaks you give in their condition are miracles to them. So it's really, really neat to see that there is some evidence being done on a systematic level that is showing that we can give some pain relief with these rehab therapies. If we go to their conclusion, manual therapy, isolated and combined therapies targeting the neck alone or neck and jaw are promising for reducing pain and tenderness in individuals with this subcategory of pain. Uh, See it in the office. We're going to keep doing it. And if you suffer from any sort of pain condition, I'm not going to promise that, we could get rid of it, but it's at least worth considering because I actually just had a patient yesterday who's gone through all sorts of alternative therapies to treat a TMJ, longstanding chronic issue from an old injury that has developed into a bunch of secondary things like, migraines from that old injury, etc. So these types of people are typically either underserved in the sense that they only think there's one or two routes, or they're overpromised and left wondering who, what, when, where, and why. So if you suffer from any sort of oral facial pain, get on my schedule. Let's have a talk. I'll let you know based on where you've been, what you've tried, what maybe you haven't tried, if we can help, and if so, how, or if we can't, who to see next. This is something that we should start nipping in the bud a bit more seriously. Next up. Oh, this one's short. So in prior studies, we talked about muscle fatty infiltration in the lower lumbar muscles, the lumbar erectors, and how if you had greater fatty infiltration, it reduced the amount of muscle tissue you had and increased your total disability and also made it more difficult to treat and reduce your pain and disability. Well, it's no surprise that we're finding the same things in the neck. And the call to action from all of those studies is we must do our parts to be as active as possible to maintain, keep, and improve the muscle tissue to reduce fatty infiltration so that we don't have uh, a population that has a bunch of fat in the muscles that makes it difficult to move, do, and everything else because then it becomes difficult to treat and manage. So stay active. If you're not already active, get active. If you're concerned about how to get active, find a provider who can guide you along the way because these chronic issues that develop from a sedentary lifestyle or after an injury that you're scared to rehab, they set in and can be nefariously difficult to treat and can often go from taking a couple weeks to a couple of months to help into the several years category. So stay active. If not, get active. If not, find somebody to get you active or a community to get you active. Chronic pain and hypertension. So, what do? Whether it's through direct mechanisms or indirect mechanisms, if you develop an issue that leaves you in chronic pain, you have a higher propensity to develop hypertension and other systemic issues in your body. And the thought is the pain causes you to do different things. So pain will make people tense. It will reduce their ability to fall asleep or stay asleep. It will impact your social drives to socialize with other people because you're scared of the pain. It will limit your activities, your physical activities. So all of those things that the chronic pain does have downstream effects that will inevitably put you at a higher risk of developing what is traditionally thought to be sedentary chronic issues in our day and age. So let's just take it piece by piece. If you're not active or as active as you used to be, exercise and movement have huge, profound effects on our overall health, including reducing hypertension, keeping excess weight off, etc. And if you're not active because you're in chronic pain, it's not that the chronic pain caused you to get hypertension. The chronic pain caused you to stop doing the lifestyle that kept you from getting hypertension. And we see the same thing in various avenues like chronic pain. People usually have a coping mechanism that could include a snack or something that takes the pain away. The movie model is typically alcohol. So chronic pain can lead to alcoholism. That has its own issues. Chronic pain can lead to overeating in the sweets to numb the pain, so to speak. Diabetes. You get the picture. Downstream effects from chronic pain may start subtle, but they are always nefarious. Get yourself somebody in your corner to fight for you to try and get you to maintain as healthy of a lifestyle as you can, irrespective of the chronic pain. And hopefully, over time, with the right providers, the right team, your chronic pain is either able to be eliminated, which would be great, but not always the case, or at the very least managed successfully for you to enjoy the best life that you possibly can. That's got to be the goal. Okay. Next up, pain management strategies and self estimated costs among Spanish individuals with chronic pain. So this one is subdivided different socioeconomic categories of people, found a couple of things to track, but really what it said is a lot of people will seek passive activities and that we should really drive for more active endeavors, as well as things that improve patients' autonomy and self-efficacy, because over-reliance on passive interventions typically will cost more in the long run, even if the active ones are an investment, because your reliance on them means you're doing them for longer. Maybe you have a pretty frequent dose that you're going into it, and they don't always have the best track record for actually getting you the results you want. So if I jump to the conclusion where they kind of sum it up, passive strategies were widely used in these subcategories, and again, they identify different risk factors, who may be paying more money, etc. Uh, Passive strategies were widely used, potentially perpetuating pain. Despite frequent use of some active strategies, promoting healthier lifestyles could improve these outcomes. That's what we're all about. The high economic burden highlights the need for more effective, cost efficient pain management approaches. So, that's going to be things that did what the previous sentence said. Developing healthier lifestyles could, and I think should, mitigate and reduce the impact, especially the economic impact, for these individuals. Last two studies. Lower urinary tract symptoms in men with chronic low back pain, a cross sectional study. This one really highlights that these symptoms can go hand in hand, and it's why you need to find a provider that isn't overly relaxed or dismissive when you're telling them the symptoms. And if you have a provider that doesn't ask a lot of questions, find a new one. A lot of what people experience is either interrelated or have the possibility of being a referred symptom from a different region of your body. We dub these things as different types of, and let's just use pain. There's viscerosomatic, psychosomatic, somatovisceral. Basically, you're putting these words in to describe what do we think the insult mechanism or source is, and where's the person interpreting it. So in men, there's a few things that you want to cross your T's and dot your I's when you're dealing with some sort of low back pain. To everybody's surprise, we have bladders, we have prostates, we have a lot going around the low back and pelvic floor area, maybe not as much or as widely respected as an origin for symptom standpoint as our female counterparts, but it's still there. So in men that have various, let's say, referral patterns of pain, so I've had men with low back pain that can refer and cause issues with bowel movements. I've had patients with low back pain that actually goes and develops to referral of testicular pain with maybe a side preference like left testicle or right. I've had patients with vague deep low back pain with urinary, not overproduction, but an overly developed sense of urgency to urinate. uh, we're also trained to ask questions on how well, if at all, you're actually able to maintain an erection, different symptoms like that that actually could be a key symptom in the actual management profile of the patient in front of you. Because if there's the potential chance that your back pain, which is the biggest reason that you came to somebody like me, for example, isn't actually musculoskeletal in nature, I can't effectively treat you from a musculoskeletal standpoint. If, and I've heard stories of this, if men have prostate tumors, cancer, if they have bladder cancer, if they have a bladder lesion, if they have an infection, if they have any of those symptoms, or any of those conditions, a common symptom often shows up as back pain for various reasons I'm not going to get into right now. I have heard of providers that are so focused on treating the person in front of them with the therapies that are in their clinic at the time that they ignore the problem at large, and the patients get either worse or their chance and ability to get better go down because they're not seeking the right intervention for them because they're so focused on just the back pain. They're not looking at a potential underlying source of what that back pain was and seeking the appropriate provider for it. So don't ignore symptoms. Don't hide symptoms from any provider because I have had patients that have either forgotten or quite literally, I'll ask them directly, do you have, in men, any testicular pain, difficulty with erections, urination, etc. Similar questions for females, um, not with certain things, but other things as well. And some people are surprised, like, why are you asking me that? Or, yeah, I have X, Y, and Z, but why do you need to know? This is why. A good provider, whether it's especially a good primary access provider where you don't need a referral to go see them. So a good doctor of physical therapy, doctor of chiropractic, um, uh, doctor of Chinese medicine, anybody that you don't need a referral note to see should be adequately trained in these screening protocols to make sure that the patients that may seek us out because their primary symptom may be what leads them to the office in the first place. Again, the stereotype for chiropractors is low back pain. Physical therapists, probably very similar. For Chinese medicine docs, who knows? Like, it's not my wheelhouse, but it's the same idea here. That may bias a patient to come see you, but I am not going to be the provider that can take care of a prostate issue. A, for a female, I'm not going to be able to take care of directly a, ovarian, fallopian tube, uterine issue. Um, and my role really becomes supportive in nature. So, especially if the person is Western medicine averse, it is still trying to get them to the right provider and then managing and co-managing with that provider who can take care and quarterback the actual problem. How can I support the person? Is it through making sure they have adequate nutrition, from certain interventions that the provider may recommend? Maybe they'll wind up with a nutrient deficiency. So common one that's well known about is if the person needs to go on a statin to sharply improve some of their blood markers, statins will reduce CoQ10. So it's like, hey, you got this guy, he's putting on a statin because he had all these risk factors. I'm going to prescribe him, a CoQ10 supplement so that we don't deplete our stores and our stock. It's really about understanding from a patient standpoint. Don't hide information because you think it's not relevant. And it's also to demonstrate the best thing for you, the patient, is to find providers that are willing to collab, co-manage, and be upfront and honest about screening. So actually, a patient I had this morning asked me about bilateral hand numbness that she's only had once in a blue moon from waking up from sleep. And for me, it's just like, well, it's not, happening very often. She's actually very active. And I told her, she said she's having a physical coming up. I'm like, look, there's a lot of things it could be, but let's just knock out some of the low hanging fruit. At your upcoming physical, tell your provider these symptoms and see if they'd also be willing to get you a couple of extra blood work labs done, like with iron and with vitamin B. Let's just see if it's any of the common low hanging fruit things that can start causing this. Because as we age, different things happen, our metabolism and our kind of like our barometer of where our body sets a baseline for certain things can shift. So it's always worthwhile just to get routine lab work from a trusted provider that can watch your trends over time to really figure out where are you trending, what may start to develop, so that you don't over seek care and have to pay a whole bunch seeking a specialist for something that, as long as you had somebody watching it over a period of time, it's like, oh wait, I see what your past 5 years are like. You probably have this because we were able to track it, versus I see somebody out of the blue and now you've got like a dozen different diagnoses that you got to think about, just because it's, well, now this could be anything. I don't know anything about you. Like, I haven't been your provider for the last 5 years that could see this stuff. So if this individual, it's probably some low hanging fruit that can be easily managed with supplements and lifestyle management. And if it's not that low hanging fruit, then we just check those off and move on to the next most likely diagnosis. And if it's in our wheelhouse, we treat it. If it's not, we find the best provider for this person at that time. And that's what I wanted to say about urinary tract symptoms in men with chronic low back pain. What do, why do, how about it? Last one, I'm not going to rant nearly as much. This is just kind of highlighting one of the therapies we use. Effects of dry needling on function and pain relief in patients with chronic nonspecific neck pain. It found, like we've shown in so many other studies, it can be effective, at least in this one specifically, with chronic nonspecific neck pain. It doesn't necessarily outperform other modalities, but it does demonstrate effectiveness. So you're able to match the therapy to the patient in front of you, like all the other studies we talked about. I mean, if I just go again, I'm going to jump to the conclusion, 'cause I just am. Dry needling is an effective rehab therapy and pain relief, but it is not superior to physical or manual therapy in terms of function in patients with chronic nonspecific neck pain. Further high quality studies are needed to broaden the research in this actually, I kind of like how they phrase that, mini invasive approach for neck pain. So again, we get to have the luxury and the backing that we can be agnostic to a certain degree with the therapies that we choose for patients. And that to me only benefits the broader patient base at large. There's a few exceptions to this rule, but I like the fact that those are exceptions to the rule and not the rule itself. Because if the world was what I presumed it to be when I went into grad school, where there was a specific treatment for every single condition, having been out in the field long enough, I think I would have been exhausted, because you have to then communicate. And again, this is make believe world. You would have to communicate and get additional patient buy-in potentially for a therapy they don't want, if it's the best for them, because it's the only thing that mechanistically would work. So if I had to treat, or if I had to be able to think that dry needling only works with X and Y, adjustments only work in, scenario A, instrument assisted work only works in scenario B, which has some overlap with scenario C with your hand, it would have been a nightmare. And I'd be able to, would I be able to sleep at night? Like, man, did I choose the right therapy for Susan? Did I choose the right therapy for Bill? Because this one's better here. This one's better. It's like, it would have been a mess. Letting me have the exceptions to the rule. Um, so the few that I need to be aware of in my back pocket, cool. The entire rest of my patient base, we get to have an honest conversation about, hey, these all help. This one may be slightly better because it's the exception to the rule. But as long as we communicate what I think should happen, what you should feel, which one are you most comfortable with? A or B? A? Sweet. We'll do A for you. Let's see how you respond. You didn't respond real well with A? Sweet. We can toss it. Let's just do B. So much better for everybody involved. But that's all I have to say. So until next week, thanks for sticking with me.